everyone. I am myself Dr. Rajesh Gubba. In this session, I will be discussing a very important topic, that is bronchogenic carcinoma. So, bronchogenic carcinoma, it is a malignant neoplasm of the lung. And this particular malignant neoplasm of the lung, it arises from the epithelium of the bronchus or the bronchiole. And we have following types of the bronchogenic carcinoma. That includes, number 1, squamous cell carcinoma, and second is adenocarcinoma, and next we have small cell carcinoma. So this small cell carcinoma, this is also called as the oat cell carcinoma. And lastly we have large cell carcinoma. So these are the types of the bronchogenic carcinoma. Now, if you see the etiology of the bronchogenic carcinoma, most common cause for the development of bronchogenic carcinoma is smoking, right? So that is, cigarette smoking, it constitutes nearly around 85 to 90% causes of bronchogenic carcinoma. Now, apart from smoking, we have certain environmental risk factors for the development of the lung cancer. So, if you take the right. So if you take the environmental risk factors, let me tell you, mainly it is the radon gas. Radon gas exposure is commonly seen among the uranium miners. Okay, so exposure to radon gas. So this particular radon gas exposure is commonly seen in those individuals, right, who are the uranium miners. And this radon gas exposure is also seen in areas where radium in the soil causes significant indoor air contamination. That is, so please remember, radon gas is one of the very important etiology for your bronchogenic carcinoma. And next thing is asbestos exposure. Asbestos, as such, it will cause mesothelioma. But along with asbestosis, or along with asbestos exposure, if the individual is also a smoker, then there is almost 60 to 100-fold, right, 60 to 100-fold increase in the development of bronchogenic carcinoma. Then metals. So if you see the metals like arsenic, then chromium, next followed by that nickel, and iron oxide. Right, so these are the metals which are responsible for the development of bronchogenic carcinoma. And we also have certain industrial carcinogens. These industrial carcinogens include bischloromethyl ether. So, this bischloromethyl ether, which is an industrial carcinogen, this is also responsible for the development of bronchogenic carcinoma. So, among all these, cigarette smoking, it constitutes nearly around 85 to 90% of causes of the lung cancer. Now, so we have discussed the types like adenocarcinoma, squamous cell carcinoma, small cell carcinoma, and then we have large cell carcinoma. Now, if you see this question here, most common type of carcinoma lung is. Now, the answer to this question is, okay, let me discuss and then come back to this question. So out of this, let me take up the discussion of adenocarcinomas first. adenocarcinomas, right? I'll discuss all the types of bronchogenic carcinoma and then I'll come back to this question, okay? Right. So adenocarcinomas, they constitutes about 48% of cases. And where do they arise from? They arise from the mucous glands. Right, they arise from the mucous glands or from any epithelial cells within or distal to the terminal bronchioles. So, they also arise from they also arise from the epithelial cells within or distal to the terminal bronchioles. So, that is where the adenocarcinomas originate from. And where will be the location of these adenocarcinomas? They usually present as peripheral nodules or masses. Right? They usually present as the peripheral nodules or masses. Right? That is the location of this adenocarcinoma. They are peripheral tumors. They are not central tumors. They are peripheral tumors. And we have another terminology called adenocarcinoma in situ. Now, what do you understand by this term? Right? What do you understand by this term? Adenocarcinoma in situ. Adenocarcinoma in situ, it is, see, previously this adenocarcinoma in situ was called as bronchoalveolar cell carcinoma. This adenocarcinoma in situ, it spread along the pre-existing alveolar structures without evidence of the invasion. Right? It spread along pre-existing alveolar structures. Right? So that is what is your adenocarcinoma in situ. Then the next important point I want to tell you here is, among all the types of bronchogenic carcinoma, it is the most common type of the bronchogenic carcinoma. Right? It is the most common type of bronchogenic carcinoma. Please remember that. And in which gender it is commonly seen? It is more commonly seen in females rather than males. And this adenocarcinomas, they are seen in non-smokers. This is a very important point. Right? Seen in case of non-smokers. As such, what we have discussed, the etiology, most common cause for bronchogenic carcinoma is smoking. But whereas adenocarcinoma, it is associated in individuals who are non-smokers. And most of the tumors, as already I have said you, they are they are peripherally growing tumors. Right? They are peripherally growing tumors. Because they are peripherally growing tumors, they do not cause the pulmonary symptoms in early stage. Right? They do not cause pulmonary symptoms in early stage. So when do you think the individual will develop the pulmonary symptoms? The individual will develop pulmonary symptoms only when it is the central tumors. But these are the peripheral tumors. So because these are peripheral tumors, they don't cause compression of the respiratory tree. That is the reason why you don't have the symptoms in the early stages of the adenocarcinoma. See, most of the times, these adenocarcinomas, they are found incidentally on the chest X-ray. Right? Most of the time, they are found incidentally on the chest X-ray. And this adenocarcinoma, it is a slow growing tumor then compared to that of the squamous cell carcinoma. Right? It grows right? It grows more slowly than the squamous cell carcinoma. But this tumor, it will tend to metastasize widely and early, right? So it undergoes metastasis widely and early, and in this tumor it is associated with scarring, right? This tumor, it is associated with scarring. Now if you see a very important question here, most common carcinoma lung, no doubt in that, it is adenocarcinoma, whereas most common carcinoma lung in India, it is squamous cell carcinoma, right? Please remember, these 2 points are very, very important points. Right, in India, it is squamous cell carcinoma. So if you see this question now, most common type of carcinoma lung, it is adenocarcinoma, because particularly the word India is not being mentioned here. So that is the reason why the answer is adenocarcinoma. Now, you see another question. What is the true statement about the adenocarcinoma lung? It is more common in females. Smoking, it is associated with smoking. Central cavitations. Upper lobe involvement is most common, then the peripheral involvement. So, true statement about adenocarcinoma lung is that it is more common in females and peripheral involvement is being present. Now, to summarize adenocarcinoma, right? So, it is seen in 48% of individuals. So, please remember these 5 P's of adenocarcinoma: peripheral location, poor prognosis, peripheral scar formation, yes, it will be present, and preponderance, if you see that it is more common in women rather than men, and it progresses slowly. It's a slow growing tumor. So please remember these 5 P's of the adenocarcinoma. Now, followed by that, you take the small cell carcinoma. See, small cell carcinomas are the tumors of bronchial origin, right, of bronchial origin, and these small cell carcinomas, these are centrally located tumors, right? These are centrally located tumors, and these tumors which are centrally located, they infiltrate submucosally. Right, they infiltrate submucosally to cause narrowing of the bronchus. Right, to cause narrowing of the bronchus. Okay, and because of the narrowing of the bronchus, the individual can have difficulty in breathing and as well as dyspnea. Difficulty in breathing is nothing but dyspnea, and they can also have wheeze. And these are the most aggressive tumors, right? These are the most aggressive tumors, and they undergo, right, they undergo regional or even distant metastasis as well, right? So there can be regional or there can be regional or the distant metastasis. So few more points about this small cell carcinoma. Small cell carcinoma, just now I said it is a oat cell carcinoma, and it's the most aggressive variant. And what is a very important risk factor? Smoking is the most important risk factor for the development of this bronchogenic carcinoma, and it is centrally located tumor, and it is an aggressive tumor. So that is the reason why it has worse prognosis. It can undergo regional and as well as the distant metastasis as well. So that is the reason why it is associated with worst prognosis, right? And to summarize this small cell carcinoma, please remember this mnemonic, that is CHIP. C stands for central location, and it also causes cavitation. H stands for hemoptysis, and there can be hilar lymphadenopathy. I, invasion to the regional and distant sites, and this particular invasion, it is through lymphatic spread, and it is the one which will progress rapidly, right? It's an aggressive tumor. Okay, so remember, small cell carcinoma is the only aggressive tumor. It is small but sinister. That means it is highly aggressive. Now, after having discussed about the small cell carcinoma, let me discuss about the squamous cell carcinoma. Squamous cell carcinoma, it arises from the bronchial epithelium. Right? It arises from the bronchial epithelium, and it is often present as the intraluminal mass. Right? It is often present as the intraluminal mass, and they are also centrally located tumors. Right? They are also centrally located tumors, and these patients, they present with, right, these patients, they present with hemoptysis. And the mnemonic for squamous cell carcinoma that you need to remember is again the same, that is the CHIP, centrally located tumor, hemoptysis, invasion, that is spreads by the local invasion. But small cell carcinoma, what did we discuss? It spreads through lymphatics. It has a distant spread, right? Whereas this is like local invasion. Which one? The squamous cell carcinoma. And it progresses slowly. Which one? The squamous cell carcinoma. Okay. Now, after having discussed about the squamous cell carcinoma, let me tell you about the large cell carcinoma. Large cell carcinomas, these are the heterogeneous group of undifferentiated cancers. Right, heterogeneous group of undifferentiated cancers that share large cells and do not fit into the other categories. So basically these are the heterogeneous group of undifferentiated cancers, and these are also aggressive tumors like that of your small cell carcinoma, right? And they have rapid doubling time. Right, they have rapid doubling time, and they are present centrally and as well as peripherally. So they are central tumors and as well as the peripheral tumors. Whereas if you take the others, you take adenocarcinoma, it is a peripheral tumor. Small cell carcinoma and squamous cell carcinoma, they are central tumors. But large cell carcinoma, they present as central or the peripheral masses. So please remember 5 P's of large cell carcinoma, that is peripheral or central in location. It's a highly aggressive tumor, that is the reason why it's a poor prognosis. Peripheral scar association is not there. Peripheral scar association is seen in adenocarcinoma, and there is no particular preponderance. Males and females are equally affected, whereas in adenocarcinoma, females are more commonly affected, and it progresses slowly. So this is about the large cell carcinoma. Now, after having discussed about the important points related to various types of bronchogenic carcinoma, let me tell you symptomatology in bronchogenic carcinoma. So, if you see the question, most common symptom of bronchogenic carcinoma: cough, dyspnea, weight loss, and chest pain. So, let me tell you, right? I'll discuss the clinical features and then come back to this question. Symptomatology in case of bronchogenic carcinoma, it primarily depends upon the location of the tumor. Right? It primarily depends upon the location of the tumor. If you take the squamous cell carcinomas and as well as the small cell carcinomas, What is that we have discussed? These are central tumors. Right, these are the central tumors. They arise from the main lobar or the first segmental bronchi. So basically central tumors. So these tumors, because they are central tumors, they present with early pulmonary symptoms. Right, they present with early pulmonary symptoms. So these pulmonary symptoms, they result from the direct effect of the tumor. Right, these pulmonary symptoms, they occur from the direct effect of the tumor on the bronchus or lung tissue. Right, direct effect of the tumor on the bronchus or the lung tissue. And pulmonary symptoms secondary to central or endobronchial growth of the tumor. So basically, what did I tell you just now? It all depends upon the location of the tumor. Right, and this small cell and as well as the squamous cell carcinomas, they cause direct effect of the tumor on the bronchus or lung tissue. Now accordingly, what will be the symptoms? First and foremost, most common symptom, right, most common symptom will be cough. And this particular cough, it is secondary to, right, it is secondary to irritation or compression of the bronchus. Right, they are secondary to irritation or compression of the bronchus. Then next important symptomatology is dyspnea. Right, next important symptomatology is dyspnea. So this particular dyspnea, it is usually due to central airway obstruction. The tumor, it can cause obstruction of the central airway. Right, it can cause the central airway obstruction, or this particular tumor can cause compression with or without atelectasis. So because of central airway obstruction, this tumor can cause dyspnea. Next important thing is wheezing. Right, next important thing is wheezing. See, wheezing is mainly because of narrowing of the central airway. Right, narrowing of the central airway, and this particular narrowing, it is more than 50%. Right, this particular narrowing is more than 50%. Then the next important clinical manifestation is the hemoptysis. So if you take the pulmonary symptoms secondary to central or endobronchial growth, we have already discussed cough and as well as dyspnea and wheezing. The other features are hemoptysis. You will have a typically blood streaking of the mucus. And if there is presence of hemoptysis, that indicates the central airway obstruction. And this central airway obstruction is seen in small cell carcinoma, squamous cell carcinoma, and even large cell carcinoma. Then coming to the pneumonia, even the presence of pneumonia is also due to airway obstruction. See, whenever there is an airway obstruction, the secretions, they don't get expectorated out, and accumulation of the secretions within the lung parenchyma, can form a source of infection to the infectious organisms, causing the individual to develop pneumonia. And this particular pneumonia, if it is not adequately treated, the individual can progress to the development of the lung abscess, right? Lung abscess. So, in the lung abscess, what is that you will observe? The necrosis of the lung tissue, and there can be also cavitation once that necrotic material is completely expectorated out. So, that is what is your lung abscess. Lung abscess is the result of inadequate treatment of pneumonia, what you will see in patients with the bronchogenic carcinoma. So, the pulmonary symptoms, they are produced due to central location of small and as well as the squamous cell carcinoma. So, if you take the most common symptom of lung cancer, what will be that? It is the cough. And this particular cough, it is associated with copious expectoration. Right, it is associated with copious amount of expectoration, and this particular expectoration, if you take the consistency, it is serous inconsistency. So this will be the symptomatology that you will see in bronchogenic carcinoma. So most common will be cough. Then there will be also weight loss. And why there is weight loss? That is because of excessive metabolic activity in any of your malignancy. And there can be dyspnea, and this particular dyspnea is due to compression of the airways. There can be chest pain. And why is that? That is because of the spread of the carcinoma to the pleura, right? That can cause the pleuritic chest pain. There can be also hemoptysis. There will be bone pain. Why there is bone pain? That is because of the spread of the tumor to the bone, that due to metastasis of the tumor to the bones. There can be clubbing, fever in case of pneumonia, weakness, and there will be also superior vena cava obstruction. So these are all the signs and symptoms in patients with bronchogenic carcinoma. Out of this, the most common symptom will be cough. So mainly we have discussed now the clinical manifestation related to the centrally located tumors, right? In centrally located tumors, these are all the manifestations that you have seen. But in case of peripherally located tumors, what will be the manifestations? Let me discuss that now. So, in case of peripherally located tumor, see, in contrast to these centrally located tumors, adenocarcinoma is often peripherally located. And for this reason, they are often discovered incidentally as an asymptomatic peripheral lesion on the chest X-ray. Okay, so the peripherally located tumors are adenocarcinoma, right? And these adenocarcinomas, they are asymptomatic right? They are asymptomatic in the early stage of the disease. And that is the reason why most of the times they are found incidentally on the chest X-ray. And when the symptoms occur, they are due to a pleural or chest wall invasion. Right? If the symptoms occur, they are due to either pleural or due to the chest wall invasion. So, now what will be those features? So, symptoms secondary to peripheral growth of the primary tumor, they include pain from pleural or chest wall involvement. So, I said you peripherally growing tumor, right? Because it's a peripherally growing tumor, it mainly spreads to the pleura. So that is the reason why the individual can have the pleuritic type of chest pain. The individual will have cough, that is because of the irritation of the tumor over the lung parenchyma. And as the severity increases, there can be dyspnea as well, because this particular tumor, it will cause restrictive effect right? It will cause restrictive effect. So the lung expansion does not occur. And apart from that, there can be also lung abscess syndrome. Right, so there can be also development of lung abscess syndrome. And this particular lung abscess syndrome, it is mainly from tumor cavitation. Right, it is mainly from the tumor cavitation. So if you see this question now, type of lung carcinoma producing the superior vena cava syndrome. Okay, now let me discuss the next important, that is the superior vena cava syndrome. What is this superior vena cava syndrome and what is the tumor which will cause superior vena cava syndrome? Let me take up. The options are squamous cell carcinoma, adenocarcinoma, small cell carcinoma, and as well as the anaplastic carcinoma. So superior vena cava syndrome is that the tumor of the lung will cause the compression of the superior vena cava, and that makes the individual to develop what is called superior vena cava syndrome. And most commonly it is seen in case of the highly aggressive tumor, that is small cell carcinoma. Now, what will be the clinical features in these patients with the superior vena cava syndrome? So the enlarging tumor or the enlarging lymph node, it will compress the superior vena cava. So what will be the symptoms? You can observe the individual over here, right? What is that you are able to make out? There is facial swelling, right? So there will be swelling of head, neck, and as well as the arm. Then followed by that, if you see the veins here, you will have the prominent veins over the chest wall. Right, you have the presence of prominent veins over the chest wall. There can be also development of conjunctival edema, right? And finally, there can be also pericardial effusion. So these are the clinical features in superior vena cava syndrome. Now, apart from SVC syndrome, another important complication in case of bronchogenic carcinoma is the Pancoast syndrome. Now, what do you understand by this word Pancoast tumor, or what is this Pancoast syndrome? It is seen in case of the adenocarcinoma, right? Pancoast syndrome is seen in adenocarcinoma. And not only adenocarcinoma, the next most common tumor which can cause the Pancoast tumor or the Pancoast syndrome will be squamous cell carcinoma of the lung. Now what exactly happens here? In case of the adenocarcinoma, I said you it's a peripheral tumor. This peripheral tumor which is growing at the apex of the lung, right? The tumor which is growing at the apex of the lung, this tumor can cause the compression of C8, T1 and T2. And because of the compression of C8, T1 and as well as T2, the individual will develop what is called as the Horner syndrome. Right? The individual will develop what is called the Horner syndrome. Now, apart from this particular Horners, the other features are the presence of the shoulder or arm pain. Right, shoulder and as well as the arm pain, because it is your C8, T1, T2 which is supplying to your arm. Now, what will be the features of the Horner syndrome? See, Horner syndrome, it occurs whenever there is damage to the sympathetic chain or sympathetic ganglion. Right, sympathetic ganglion. Now, what will be the features of this particular Horner syndrome? So the features of the Horner syndrome, they include ptosis, right, which is nothing but the drooping of the eyelid, and number 2, there will be meiosis, right, where there is constriction of the pupil. There will be inophthalmos, right. Inophthalmos is where there will be inward movement of the eye. Anhidrosis, where there will be absence of sweating. And next, there will be loss of ciliospinal reflex. So these are the features of the Horner syndrome. And this Horner syndrome, it can be seen in patients with the Pancoast syndrome. Pancoast syndrome is seen in individuals with adenocarcinoma, then followed by that in patients with the squamous cell carcinoma. So, if this question is asked, type of the lung carcinoma producing superior vena cava syndrome, that will be your small cell carcinoma. But the type of tumor which will cause Pancoast will be your adenocarcinoma. So, the next question, if you see in bronchogenic carcinoma, following hormonal levels are increased in small cell carcinoma of the lung except adrenocorticotropic hormone, growth hormone, atrial natriuretic factor, and as well as the arginine vasopressin. Let me tell you, this bronchogenic carcinoma, it acts as the paraneoplastic syndromes, wherein there will be ectopic hormone production, right? And these ectopic hormones, they are being produced by the lung carcinomas. Now, what are these particular ectopic hormones? Let me take up the discussion. First of all, you see in case of small cell carcinoma, small cell carcinoma, it produces ACTH in excess quantity. Now, because it produces ACTH in excess quantity, the individual can develop Cushing syndrome. Then, this small cell carcinoma, it will also produce antidiuretic hormone in excess quantity, and that makes the individual to develop what is called SIADH. That is syndrome of inappropriate antidiuretic hormone. And this small cell carcinoma, it also produces calcitonin, right? It also produces calcitonin. Now, because this small cell carcinoma produces calcitonin, this can make the individual to develop hypocalcemia, because calcitonin is the one which will reduce the blood calcium levels. And this small cell carcinoma can also produce gonadotrophins. Now, because it produces gonadotrophins in excess quantity, they will make the individual to develop what is called gynecomastia. So, in patients with small cell carcinoma, right, in patients with the small cell carcinoma, these are all the ectopic hormones which are being produced, and accordingly you have the symptomatology or the disorder which is being occurring. And next important bronchogenic carcinoma which will be producing the ectopic hormone is squamous cell carcinoma. Squamous cell carcinoma, if you see, it will produce the parathormone, PTH. Right? It produces parathyroid hormone. And this parathyroid hormone, what it will do to the calcium levels? It will increase the calcium levels. So, this squamous cell carcinoma will cause hypercalcemia, right? And it will also cause hypophosphatemia. So, why is that there is hypercalcemia and hypophosphatemia? That is because of excessive parathormone production by the squamous cell carcinoma, right? So, these are the ectopic hormones produced by the bronchogenic carcinoma. Small cell carcinoma, it produces ACTH, antidiuretic hormone, calcitonin, and gonadotrophins. Squamous cell carcinoma produces parathormone, and that will induce the hypercalcemia and as well as the hypophosphatemia. Now, so if you see this question now, right, so following hormonal levels are increased in small cell carcinoma of the lung except, the answer is growth hormone. See, small cell carcinoma produces ACTH and that is the reason why the individual will develop Cushing's. And your small cell carcinoma also will produce atrial natriuretic factor and the individual may develop hyponatremia. And hyponatremia in small cell carcinoma is also because of the production of antidiuretic hormone as well. And arginine vasopressin is produced in excess quantity and that makes the individual to develop what is called SIADH, that is syndrome of inappropriate antidiuretic hormone, right? SIADH. Then, if you see the summary of the clinical manifestations what we have discussed, if you see, due to local effect of lung tumor spread, the individual can develop pneumonia. So, why is this particular pneumonia or abscess? That is because of the tumor obstruction of the airways. And why is that the individual will develop this lipid pneumonia? That is because of the tumor obstruction and accumulation of the cellular lipid in foamy macrophages. That makes the individual to develop lipid pneumonia. And there can be also development of the pleural effusion. And this pleural effusion in case of bronchogenic carcinoma is due to tumor spread into the pleura. And in this bronchogenic carcinoma, there can be also development of hoarseness of voice, and that is due to involvement of the recurrent laryngeal nerve. So, recurrent laryngeal nerve invasion will make the individual to develop what is called the hoarseness of voice. So, these are the local effects of the lung tumor spread. Now, this particular bronchogenic carcinoma can also spread to the surrounding structures, and accordingly, what will be the manifestations? There can be dysphagia, right? And dysphagia is mainly due to esophageal invasion of the bronchogenic carcinoma. And there can be invasion into the phrenic nerve causing the diaphragmatic paralysis. And because of diaphragmatic paralysis, right, because of diaphragmatic paralysis, the individual will develop type 2 respiratory failure. And this bronchogenic carcinoma can also undergo chest wall invasion causing destruction of the rib. This bronchogenic carcinoma, particularly small cell carcinoma, can compress the superior vena cava causing superior vena cava syndrome, right? And in Pancoast, like adenocarcinoma, you will have Pancoast, right, where you have the development of the Horner syndrome. And this bronchogenic carcinoma can also spread into the pericardium causing pericarditis and as well as the cardiac tamponade. So, these will be the effects of the tumor either due to the local spread or due to the distant spread. Now, after having discussed about the features of bronchogenic carcinoma, let me discuss how to diagnose this bronchogenic carcinoma. See, first and foremost, very important is the sputum examination. See, in the sputum, like how many sputum samples you have to take? Like more than 5 sputum samples you have to take, right? Why? That is mainly to improve the sensitivity and specificity. But whatever is that, like if you do a sputum examination and if you want to diagnose bronchogenic carcinoma, the sensitivity is only 69%. Right? Sensitivity is only 69% and the specificity is 96%. Okay, so that is about like diagnosing bronchogenic carcinoma based on the sputum examination. Then the next important investigation in the bronchogenic carcinoma is the chest X-ray. See, chest X-ray is one of the first investigative steps if a patient reports the symptoms that may suggest the lung cancer. Right? This is the first investigative steps. And what does the chest X-ray shows? The chest X-ray, it will reveal the presence of an obvious mass. Right? It will reveal an obvious mass. And there can be also widening of the mediastinum as well. And it all depends upon the location of the tumor. Right? There can be also widening of the mediastinum. Then followed by that, the another important investigation is the HRCT, that is high resolution CT scan. See, the purpose of this particular HRCT is mainly to evaluate the size of the tumor. Right, that is mainly to evaluate the size of the tumor. And HRCT will also tells you how is the spread of the tumor, right? And HRCT will also tells you is there any destruction of the surrounding tissue by the tumor. So that is what the HRCT shows. But what is the investigation of choice in case of particularly central tumors? Which are your central tumors like small cell carcinoma, squamous cell carcinoma, large cell carcinoma? It can present as both. So investigation of choice for central tumors is bronchoscopy plus biopsy. Okay, so this will be the investigation of choice in case of bronchogenic carcinoma. And what is the purpose of this fiber optic bronchoscopy? See, fiber optic bronchoscopy, it allows the visualization of the major airways, right? It allows the visualization of the major airways, and with the help of the fiber optic bronchoscopy, we will be also able to pick up the bronchoalveolar lavage and the cytological brushing of the visible lesions can be made out. Okay, cytological brushing of the visible lesions. So with the help of fiber optic bronchoscopy, we will be also able to take up the specimen from the visible lesions, right? Or you can collect even the bronchoalveolar lavage with the help of your fiber optic bronchoscopy. So direct biopsy of endobronchial abnormality, the sensitivity of diagnosis is very high, right? So that will be the investigation of choice. So investigation of choice will be like bronchoscopy and biopsy. And fiber optic bronchoscopy, it will not only help you to make out the biopsy, it helps you to visualize the major airways. It helps you to take the cytological brushings of the visible lesions, right? And even it will also help you to collect the bronchoalveolar lavage of the lung segments for the cytological evaluation. So that is about the importance of the fiber optic bronchoscopy. Then next is the tumor markers. See, the tumor markers, number one, CEA. So what does this CEA stands for? That is carcinoembryonic antigen. So carcinoembryonic antigen, it will be elevated in case of metastatic cancer. Right, it is elevated in case of metastatic cancer. And we have another important tumor marker, that is NSE. So what does this NSE stands for? That is neuron specific enolase. So neuron specific enolase, it is the prognostic marker in small cell carcinoma. Right, it is a prognostic marker in case of the small cell carcinoma. That is what is your NSE, that is neuron specific enolase. Now, these are the investigations. So after having discussed about the investigations, now let me tell you the staging of the bronchogenic carcinoma. So the staging, like what we have is the TNM staging. Right, the staging is the TNM staging. So if you take this word TX, it stands for the tumor in sputum or bronchial washing, but not assessed in imaging or the bronchoscopy. That is what is the word TX. So the tumor is diagnosed based on your sputum or bronchial washings, but there was no assessment of imaging or the bronchoscopy. Whereas T0, there is no evidence of tumor. TIS, it is carcinoma in situ. That is your TIS. Now, if you see the tumor staging, we have T1, T2, T3 and as well as T4 staging. T1, the size of the tumor is less than 3 centimeters and it is surrounded by lung or the visceral pleura, but there is no involvement of bronchus. That is your T1. Whereas T1A MI stands for minimally invasive carcinoma, right? Minimally invasive carcinoma. So again in this T1 we have A, B, C. T1 as such, the size of the tumor should be less than or equal to 3 centimeters. And out of which, if you take T1A, the size of the tumor is less than or equal to 1 centimeter. T1B, it is 1 to 2 centimeters. T1C is more than 2 to 3 centimeters. That is about your T1, that is tumor staging. Coming to T2. See, T2 means the size of the tumor is in between 3 to 5 centimeters. So here in T1, what is that we have discussed? There is no involvement of bronchus. But in T2, there is involvement of main bronchus without carina. Right? Involvement of main bronchus without carina. That is what is your T2. And in T2 again, we have T2A and T2B. T2A, 3 to 4 centimeters. T2B, that is 4 to 5 centimeters. So that is what is your T2. So T2 as such is 3 to 5 centimeters. And there is involvement of the main bronchus without carinal involvement. Okay, next. Coming to your T3. T3, the size of the tumor is 5 to 7. See, T1 is less than 3. T2 is 3 to 5. T3 is 5 to 7. Right? That is 5 to 7 centimeters. Or the tumor of any size involving the chest wall, pericardium, phrenic nerve or stellate nodules in the same lobe. So even if the size of the tumor might be like 1 centimeter, but if the tumor is involving the chest wall, pericardium, phrenic nerve or satellite nodules are present, then it is considered to be T3. Then if you take T4, T4, the size of the tumor should be more than 7 centimeters in greatest dimension. It should be either more than 7 or any tumor with invasion of mediastinum, diaphragm, heart, great vessels, recurrent laryngeal nerve, trachea, esophagus, spine or separate tumor in different lobes of the ipsilateral lung. So, depending upon the size of the tumor or depending upon the spread of the tumor, we classify this tumor staging. T1 is less than 3 centimeters, T2 is 3 to 5 and T3 is 5 to 7 and T4 is more than 7 centimeters. Then coming to this N, that is nodal involvement. See, nodal involvement we have N1, N2 and N3. What is N1? N1 is ipsilateral, right? Ipsilateral peribronchial or hilar lymph node involvement. That is N1. N2, it is ipsilateral, mediastinal or subcarinal node involvement. Whereas N3 is like your contralateral involvement as well. So contralateral, mediastinal or hilar will be your N3. So in N1 and N2, it is ipsilateral involvement. And in N1, peribronchial or hilar. N2, mediastinal or subcarinal. N3, contralateral, mediastinal or hilar node involvement. Then coming to your M. M in your TNM stands for metastasis. So if it is M1, it is distant metastasis. If it is M1A, that is tumor in contralateral lung or pleura, pericardial nodule or malignant effusion, that is M1A. M1B, it is extrathoracic metastasis, right? It is a single lesion, but extrathoracic metastasis will be there. Whereas M1C, it is multiple extrathoracic metastasis. So this will be your TNM staging. To summarize, T, that TX, the tumor in sputum or bronchial washing, but not assessed in imaging or bronchoscopy. T0, no evidence of tumor. TIS, that is carcinoma in situ. T1, the size of the tumor is less than 3 centimeters. T2, 3 to 5 centimeters. T3, 5 to 7 centimeters. T4 more than 7 cm. Next, nodal involvement. N1 ipsilateral peribronchial or hilar node involvement. N2 ipsilateral mediastinal or subcarinal node involvement. N3 contralateral mediastinal or hilar node involvement. Coming to your metastasis, M1 is distant metastasis, M1A tumor in the contralateral lung or pleura or pericardial nodule, M1B single extrathoracic lesion, M1C multiple extrathoracic lesion. See, what is the importance of this particular staging? The importance of staging is that accordingly we will plan the treatment of the individual as well. So now let me discuss the treatment of the bronchogenic carcinoma. So let me discuss the treatment of the bronchogenic carcinoma. So basically we classify the bronchogenic carcinoma into non-small cell lung carcinoma and as well as the small cell lung carcinoma. So if you take in case of the non-small cell lung carcinoma, surgical resection, right, it offers the best chance for the cure. Now, but before doing the surgical resection, you should be able to answer the two important questions, right? The initial approach to the patient is determined by answering two important questions. One, that is the complete surgical resection technically feasible or not? Okay, surgical resection, whether it is feasible or not. And second important question is, for suppose if it is feasible, right, if the surgical resection is feasible, you have to make out whether the patient is able to tolerate the surgery or not. Okay, whether the patient is able to tolerate the surgery or not. Whether is he fit for the surgery or not. See, these two questions you should be able to make out. Then, now the point is that why the individual will not be able to tolerate. What are those clinical entities that will preclude the complete resection? For suppose if there is extrathoracic metastasis, right, if there is presence of extrathoracic mets, or if there is malignant pleural effusion, right, if there is malignant pleural effusion, this is one of the important limitation for doing the complete resection. And this extrathoracic mets to the various parts of the body. Or suppose if the tumor if the tumor is spreading to the other organs like the nearby thoracic organs. For example, if the tumor if it is spread to the heart, if the tumor if it is spread to the pericardium, or if the tumor being spread to the great vessels, or the tumor being spread to the esophagus, the tumor being spread to the recurrent laryngeal nerve, the tumor being spread to the trachea. You know, these are the limitations for the surgical resection. Or even if the tumor spreads to contralateral lymph node, right, even if the tumor spreads to the contralateral lymph node, that is also a limitation for the resection of the tumor. Now, in the previous session, I have discussed about the staging of bronchogenic carcinoma, wherein I have classified that into stage 1, 2, 3, 4. That is your TNM staging. Now, the treatment also completely depends upon the staging of the individual's bronchogenic carcinoma CVRT. See, stage 1 and as well as stage 2, they are treated with surgical resection if possible. Right? They are treated with surgical resection wherever is possible. Whereas in stage 2 and select cases of stage 1B, they have to receive an additional or they have to receive adjuvant chemotherapy. Right? They have to receive the add-on chemotherapy, that is in stage 2 and as well as select cases of stage 1B. And what is that chemotherapy and all, I will discuss. For suppose, in stage 1, if there is any surgical contraindication, right, if there is surgical contraindication, then what will you do? See, those individuals who are not candidates for surgery because of significant comorbidity, then those patients, they have to undergo stereotactic body radiotherapy. Right? Stereotactic body radiotherapy. Now, what do you understand by this word stereotactic body radiotherapy? See, this in this stereotactic body radiotherapy, it is composed of multiple non-parallel radiation beams. Right? It is composed of multiple non-parallel radiation beams. So this multiple non-parallel radiation beams, they converge. Right? They converge and allows the delivery of relatively large dose of radiation to a small, well-defined target. That is what is your stereotactic body radiotherapy. And this has to be done in stage 1 bronchogenic carcinoma when there is surgical contraindication. Then you take in the scenarios of stage 3A. See, these patients with stage 3A, they have poor outcomes if treated with surgical resection alone. Right? If you do surgical resection alone, it has found that the outcome is poor. And they have to undergo multimodality. And this multimodality treatment includes chemotherapy or radiotherapy or both. Right? Chemotherapy or radiotherapy or both. And for suppose, in inoperable cases, what will you do? Right? Inoperable stage 3A and as well as stage 3B patients, they have to be treated with concurrent chemotherapy and radiotherapy. Right? They have to be treated with concurrent chemotherapy and radiotherapy. Right? They have improved the survival when you are using both chemotherapy and as well as the radiotherapy. So this is about your stage 3A. Whereas if you take stage 4 patients, they are treated with systemic therapy. Right? Now, what does this systemic therapy includes? Right? What does this systemic therapy includes? This systemic therapy, it includes the targeted therapy. Right? I'll explain you in detail what do you understand by this word targeted therapy. Then chemotherapy or immunotherapy. Right? Or immunotherapy. So that is about the treatment of stage 4. So stage 4 patients, they are treated with the systemic therapy. That includes the targeted therapy, chemotherapy or immunotherapy. Or the individual has to be treated with symptom-based palliative therapy. Right? And what is this palliative therapy also, I will discuss in detail. Okay. So that will be the treatment for your stage 4. Now, so I have discussed in detail what you have to do for stage 1, stage 2, stage 3 and stage 4. Now let me come on to what is that particular chemotherapeutic agents we use, right? And what are the adjuvant chemotherapy that we have to add. So if you take neoadjuvant therapy, that is new adjuvant therapy. So we have discussed that particularly in stage 3, right? They have to be given the adjuvant chemotherapy as well, because resection alone will not be helpful in case of the stage 3. Then what will be that neoadjuvant therapy that you have to add? This neoadjuvant therapy, it consists of giving anti-neoplastic drugs along with the surgery. And this neoadjuvant therapy is more widely used in patients with stage 3A and as well as stage 3B. Right? 3A and 3B, you need to add this neoadjuvant therapy. Now, then followed by that, what does this adjuvant chemotherapy consists of? Right? This adjuvant chemotherapy, it consists of the anti-neoplastic drugs, and that particular anti-neoplastic drug will be cisplatin containing regimens. Right, cisplatin containing regimens. So this cisplatin containing regimens have been shown to confer an overall survival benefit in at least stage 2 disease. And this cisplatin containing regimens also have been shown to confer the survival benefit even in stage 1B disease, where the tumor size is around 4 centimeters. So this will be your adjuvant chemotherapy, that is cisplatin containing regimens. Now, in case of stage 3B and as well as stage 4 non-small cell lung carcinoma, what are all the therapies that you have to do, right? So basically now I have just now discussed 1, 2, 3, 4 like what you have to do. And in stage 3A and 3B, you need to give adjuvant chemotherapy, and I have said you what is that adjuvant chemotherapy that you have to give in the 3A or 3B. And for stage 3B and as well as stage 4 non-small cell lung carcinoma, options for the therapy include targeted therapy. I'll explain you what is this targeted therapy. I will explain you in detail. Right, it includes the targeted therapy, then cytotoxic chemotherapy, then immunotherapy. Now, what is this immunotherapy? So this immunotherapy, it constitutes the checkpoint inhibitors. Right, it constitutes the checkpoint inhibitors. Now, what are these checkpoint inhibitors and all? I will discuss that in detail. So, the approach to therapy in stage 3B and stage 4 is individualized based on the molecular profiling, right? It is based on molecular profiling and it is based on PD-L1 testing. Right, PD-L1 testing. So these are the two approaches for therapy in stage 3B and as well as stage 4. Now, what is this PD-L1 testing? This test measures the amount of PD-L1 on the cancer cells. Right, this will tell you what is the amount of PD-L1 cells, PD-L1 on the cancer cells. Then What is this PDL1 actually? PDL1, it is a protein. Right? PDL1, it is a protein. It is a protein that helps to keep the immune cells from attacking the non-harmful cells. That is a function of your PDL1. Right? So PDL1 is a protein that helps to keep the immune cells from attacking the non-harmful cells in the body. And this molecular profiling is offered as next generation sequencing multi-gene assays. So stage 3B, stage 4, you need to give targeted therapy. And this targeted therapy is completely individualized, and that is based on molecular profiling and then PDL1 testing. And then you also need to give immunotherapy, that is checkpoint inhibitors. Now, let me discuss what are these checkpoint inhibitors. See, we have certain mutations, and those mutations are responsible for the development of the bronchogenic carcinoma. Then what do you mean by these checkpoint inhibitors or immunotherapy is that whenever you give this immunotherapy or checkpoint inhibitors, that will target that particular mutation. Okay, first of all, you should know what are the key driver mutations in lung cancer. Right? So if you take the key driver mutations in lung cancer, that includes EGFR mutation, ALK gene mutation, BRAF gene mutation, ROSL mutation. Right? These are the key driver mutation genes. These are the key driver mutations which are responsible for the development of bronchogenic carcinoma. Right? But only a minority of the lung cancer cases, they harbor these mutations. Right? They harbor these mutations. Only minority. And you have to do that molecular profiling, and then you need to check whether these mutations are there within the individual or not, and you have to target that particular mutation. And another important mutation commonly seen in smokers. Right? Mutations more commonly found among smokers will be KRAS mutation. Right? That will be KRAS mutation. That is more commonly found among smokers but has not been targeted effectively. Right? But has not been targeted effectively. Now, let me take up what will be the chemotherapeutic regimen that you will give to these mutations now. See, if they, by doing molecular profiling and as well as the PDL1 testing, you should be able to make out whether that particular mutations are there within the individual or not. For suppose, if there is activating EGFR mutation, right? If there is activating EGFR mutation, this activating EGFR mutation is usually found among non-smokers. Right? Usually found among non-smokers to light smokers, and also seen in females, and also seen in those persons with non-squamous histologies, like particularly in adenocarcinomas. Right? Particularly in adenocarcinomas. Now, what is that chemotherapeutic regimens we give in these individuals? We give EGFR tyrosine kinase inhibitors. Now, what are the examples of this EGFR tyrosine kinase inhibitor? That includes osimertinib, second erlotinib, third gefitinib, fourth afatinib, right? And fifth, we give dacomitinib. Right? Next, we give dacomitinib. These are your EGFR tyrosine kinase inhibitors, and these are given for patients with EGFR mutations, right? And this we consider as first line therapy for patients with EGFR mutations. And if you take the response rates with EGFR tyrosine kinase inhibitors, the response rate is around 70%. Right? Response rate is around 70%. And median survival is around 21 to 33 months. Okay, so that is what is the treatment for EGFR mutations. See, they can ask you multiple choice question. Which among the following is not EGFR tyrosine kinase inhibitor? Right? They will give you three options like osimertinib, erlotinib, and gefitinib, and then the other one they'll give you rituximab. Okay, so the answer will be your rituximab there. Okay, so you have to know what are your EGFR tyrosine kinase inhibitors. Then, if you take this osimertinib, it is a third generation irreversible EGFR tyrosine kinase inhibitor. Right? It is a third generation irreversible tyrosine kinase inhibitor. Now, what is the advantage of this osimertinib is, osimertinib, if it is an FDA approved first line treatment, right? See, EGFR tyrosine kinase inhibitors, we have totally 5 drugs. That is osimertinib, erlotinib, gefitinib, afatinib, and dacomitinib. See, among these, the first line is your osimertinib. Now, let me discuss few points about this osimertinib. So, this is your first line treatment among the EGFR mutations, right? That now, what is the reason why this osimertinib is being selected? Because it has long duration of action, right? It has long duration of action. And second, the individual have longer progression-free survival. Right? Longer progression-free survival. And third important is, they have lower rates of severe adverse events. Right? Low adverse effects. That is the reason why this osimertinib is being considered as the first line treatment among EGFR mutation. Then another important mutation that you have to know in case of bronchogenic carcinoma is ALK rearranged lung cancers. See, this ALK rearranged lung cancers, they contribute around 5% of all patients with non-small cell lung carcinoma, right? And in this ALK rearranged lung cancer, there is translocation of ALK, right? There is translocation of ALK. So, because of the translocation of ALK, that results in the formation of a novel fusion gene. Right? That will result in the formation of novel fusion gene. And this novel fusion gene, it has oncogenic activity. Right, it has oncogenic activity. Now, in which group of individuals you have this ALK rearranged lung cancers? It is comparatively seen in younger population. Right, comparatively seen in younger population with adenocarcinoma histology. Right, with adenocarcinoma histology, and it is also seen in non-smokers or light smokers. You have this ALK rearranged lung cancers. So, for patients with ALK rearranged lung cancers, you need to give ALK tyrosine kinase inhibitors. Right, you need to give ALK tyrosine kinase inhibitor. Now, what are the examples of this ALK tyrosine kinase inhibitors? That includes alectinib, second, ceritinib, third, we have crizotinib, fourth, we have brigatinib, and lorlatinib. Right, that is lorlatinib. So these are the examples of the ALK tyrosine kinase inhibitors, and they have to be given in individuals who have ALK rearranged lung cancer. Now, among these, right, we have many ALK tyrosine kinase inhibitors. Among these, which is considered as the first line agent? See, recent randomized trials have shown that alectinib, right, so recent trials have said that the alectinib compared to that of crizotinib, right, compared to that of crizotinib, is given as the first line treatment for ALK rearranged lung cancers. Right, and this alectinib is now recommended as a first line agent in ALK rearranged lung cancer. Then we have ROSL rearrangements, which is responsible for the development of non-small cell lung carcinoma. So this ROS1 rearrangements responsible for the development of bronchogenic carcinoma, it is seen in 1 to 2% of patients with non-small cell bronchogenic carcinoma, and it is usually found among non-smokers. Right, usually found among non-smokers or light smokers with adenocarcinoma. Right, with adenocarcinoma. Now, what are the chemotherapeutic drugs which will give the treatment in case of the ROS1 rearranged lung cancers? That includes crizotinib. Right, that includes crizotinib. So, with the help of crizotinib, the response rate is around 70%. This crizotinib is also given in case of the ALK rearranged tumors, and crizotinib is also useful in case of the ROS1 rearranged tumors. Okay. Now, another important mutation what we have in bronchogenic carcinoma is BRAF mutation. This BRAF mutation, this have been found in 2% of non-small cell lung carcinoma, right, and it is also the mutation which is seen in smokers. Now, what is the treatment you have to give if the individual harbors the BRAF mutation? You need to give a combination, and that combination includes dabrafenib, right? Dabrafenib. This dabrafenib, it is BRAF inhibitor. Right, it is BRAF inhibitor. So you need to give a combination of dabrafenib and tramitinib. Right, tramitinib. And what is this tramitinib? It is MEK inhibitor. Right, it is MEK inhibitor. So when you give a combination of this dabrafenib and tramitinib, this have shown the response rates of over 60% in the patients. Right, so this is about your BRAF mutation. And another important mutation particularly seen in smokers is your KRAS mutation. See, this KRAS mutation, it is found among 25% of patients with adenocarcinoma. And this KRAS mutation, it is also found to be associated with, right, it is also found to be associated with smoking. And this KRAS mutation, let me tell you, it is the one which has poor prognosis. Right, it is the one which has very poor prognosis. Now, there are trials for the drugs that you have to give in KRAS mutation. So we have a novel KRAS inhibitors. Right, we have novel KRAS inhibitors. And these novel KRAS inhibitors include AMG 510, right? So this AMG 510, it is given in treating KRAS G12C mutated lung cancer. But just remember, KRAS inhibitor is your AMG 510. So this is about the treatment of your non-small cell lung carcinoma. So where will you do molecular profiling and PD-L1 testing? That is in stage 3B and stage 4. And in stage 3B and stage 4, in those individuals who harbor these mutations, you need to give these particular drugs. Right? Otherwise, we give this cisplatin-based regimens. Right? Or otherwise, surgical resection is ideal in case of non-small cell lung cancer. And in those individuals who are not fit for surgical resection, you need to give the adjuvant chemotherapy, that is cisplatin-based regimens. Okay? Now, coming to the treatment of small cell lung carcinoma. See, small cell lung carcinoma, the treatment is chemotherapy, right? And this chemotherapy, it includes cisplatin and etoposide. Right, cisplatin and etoposide. This combination, it is found to have an excellent response. Right, it has found to have an excellent response in limited stage disease. So, in limited stage disease, the response is almost around 80 to 90%. Right, almost 80 to 90%. And if you take the survival, see, in case of small cell carcinoma, we have two forms. One is limited stage disease and the other one is extensive stage disease. Right, limited stage and extensive stage disease. I'll discuss in detail what is that you need to give in limited stage and what is that you need to give in extensive stage. I will tell you. But what will be the median survival rates, right? And what will be the relapse rates? Let me tell you. But first of all, in case of extensive stage disease, what are the drugs you have to give? See, along with cisplatin and etoposide, in case of the patients with extensive stage disease, you also have to give checkpoint inhibitors, right? So along with etoposide, you also have to add checkpoint inhibitors. And the examples of these checkpoint inhibitors is atezolizumab, right? Atezolizumab. So this atezolizumab, it is a checkpoint inhibitor, and this is added to your etoposide and as well as even carboplatin. Right, so that is a treatment for extensive stage disease. And in case of limited small cell lung carcinoma, when you add or when you do thoracic radiation, right, thoracic radiotherapy improves the survival in patients with the limited small cell lung carcinoma, and it is given concurrently along with chemotherapy, right, along with chemotherapy. And what is that chemotherapy we add? The chemotherapy what we give in these patients with small cell lung carcinoma will be your cisplatin and as well as etoposide. And if you take the median survival for small cell lung carcinoma following the treatment in limited stage small cell lung carcinoma, the survival, 2-year survival is around 20 to 40%, and 2-year survival in extensive is just only 5%. In small cell carcinoma, it carries the worst prognosis. It has a very high chance of metastasis. So, particularly if you observe or if you see the brain metastasis, there is high rate of brain metastasis with small cell lung carcinoma, right? Even there is good response, right? Even there is good response to chemotherapy. In spite of that, there is high rate of the brain metastasis. So, prophylactic cranial irradiation, right? Prophylactic cranial irradiation has been shown to decrease the incidence of the central nervous system disease. Right, has been shown to decrease the incidence of the central nervous system disease. And this prophylactic cranial irradiation, it will also improve the survival in patients with limited stage disease. Okay, so that is about your cranial irradiation. That is given prophylactically. That is given prophylactic. Okay, why? Because in spite of good response to chemotherapy, there is high rate of brain metastasis in patients with the small cell lung carcinoma. So, having discussed about the treatment in case of non-small cell lung carcinoma and small cell lung carcinoma, the next important is the palliative therapy. So, the next important part of the treatment is the palliative therapy. So, palliative therapy, that is photoresection with NDYAG laser. This is performed on central tumors. Now, what is the purpose of doing this photoresection with the NDYAG laser on the central tumors? This will relieve the endobronchial obstruction. Right, this will relieve the endobronchial obstruction, and this will also improve the dyspnea. right? This will also improve the dyspnea, and this will also control the hemoptysis. Right, this will also control the hemoptysis. That is the purpose of doing the photoresection with NdYAG laser on the central tumors. And the next important form of the palliative therapy is external beam radiation therapy. So external beam radiation therapy is also used to control the dyspnea. Right, also used to control hemoptysis, right, and it is also used to control endobronchial obstruction. Right, and it is also used to control the pain from bony metastasis. And it is also used to control the obstruction from superior vena cava syndrome. Right, obstruction from superior vena cava syndrome. And it is also used for the treatment of symptomatic brain metastasis. Right, also useful for the treatment of symptomatic brain metastasis. So this is the purpose of your external beam radiation therapy. Now, followed by that, how will you give the palliation therapy in case of the malignant pleural effusion? So palliation of symptomatic malignant pleural effusion, how will you do is that is by repeated thoracentesis, that is thoracocentesis, number 2, pleurodesis, number 3, Pleurex catheter tube placed in the Pleurex catheter tube placed in the pleural space. These are the key interventions for palliation of symptomatic malignant pleural effusion. Right? So this is about the treatment of non-small cell lung carcinoma, treatment of small cell lung carcinoma, and then what will be the palliative therapy in bronchogenic carcinoma. Then finally, how is the prognosis? See, the 5-year survival rate, it is around 19%. Right? The 5-year survival rate for lung cancer is approximately 19%. And there are certain predictors for survival. And the predictors of survival, they include, number 1, the type of the tumor. Right? Mainly, if you take in case of the small cell lung carcinoma, they have poor prognosis compared to that of non-small cell lung carcinoma. Right? And the another important predictors include molecular profiling. And if you have done molecular profiling and if it is found to be KRAS mutation, then the prognosis is very bad. And it also depends upon the stage of bronchogenic carcinoma. Obviously, stage 3, stage 4, they carry poor prognosis. And it also depends upon patient's performance status. Right? It also depends upon the patient's performance status. Right? And it also depends upon the weight loss in the past 6 months. Okay, so these are the predictors of the survival. And those individuals who are in the extreme stages of the disease, definitely the overall survival will be very bad. So this is about your bronchogenic carcinoma. And let me take up some questions here. True statement about small cell lung cancer. Bone marrow is uncommonly involved. Destruction of the alveolar cell. Peripheral in location. Treatment is chemotherapy. So your small cell lung cancer, the one which carries the worst prognosis, it is a central tumor. Right? It is a central tumor. Whereas the tumor which is located peripherally is your adenocarcinoma. Right? It is adenocarcinoma. So true statements is destruction of alveolar cell, it is a true statement, and treatment is chemotherapy, that is also the true statement regarding your small cell lung cancer. Now let me discuss some most commons related to your bronchogenic carcinoma. So if the question is asked most common benign tumor of the lung, then the answer will be hamartoma. And if the question is asked what is the most common cause of recurrent hemoptysis, the answer will be bronchial adenoma. And if the question is asked what is the most common cause of the cancer death, that will be your lung cancer. And what is the most common risk factor for the development of bronchogenic carcinoma? That will be smoking. And what is the most common natural risk factor for the development of bronchogenic carcinoma? That is exposure to the radon gas. Right? That is the most common natural risk factor. And what is the most common rib destroyed in Pancoast tumor? That will be the first rib. And what are the most common nerve roots involved in Pancoast tumor? Most common nerve roots involved in Pancoast tumor are C8, T1 and then T2. These are the most common nerve roots involved in the Pancoast tumor. Then the next important thing is what is the most frequent histological type? Most frequent histological type is adenocarcinoma. And most frequent histological type in India, that will be squamous cell carcinoma. And most common histological variety in non-smokers, that will be adenocarcinoma. And most common histological variety in young patients, it is adenocarcinoma. And most common histological variety in females, again the answer is adenocarcinoma. And what is the most common site for metastasis from carcinoma lung? That is to the liver. And most common endocrine organ to be involved by metastasis of the carcinoma lung, that will be the adrenal gland. Right, that will be the adrenal gland. Then next questions are carcinoma lung which metastasize to the opposite lung, that will be adenocarcinoma. And most common tumor to metastasize to the heart, that will be your carcinoma lung. And what is the histological variety that will cavitate? That will be your squamous cell carcinoma and as well as the large cell carcinoma. They are the one which will undergo cavitation. And histological variety that is central in distribution, that will be your squamous cell carcinoma and small cell carcinoma. And histological varieties that are peripheral in distribution will be adenocarcinoma. And most common variety associated with paraneoplastic syndromes, that will be small cell carcinoma. right? Most common histological variety associated with paraneoplastic syndromes will be small cell carcinoma. And few more questions are most common associated with hypokalemia will be small cell carcinoma. Why? Because small cell carcinoma will act as an ectopic source of the ACTH. And this ACTH will cause the release of your corticosteroids. And corticosteroids, when they are present in excess quantity, they have aldosterone-like action, and aldosterone will cause sodium retention and potassium excretion, resulting in hypokalemia. And most common variety associated with hypercalcemia will be squamous cell carcinoma. Why is that? Because the squamous cell carcinoma, it is a paraneoplastic syndrome or it is a paraneoplastic cancer which will produce the parath hormone, and that is the reason why you have this hypercalcemia. And histological variety most responsive to chemotherapy, that will be your small cell carcinoma of the lung. And histological varieties that respond to your radiotherapy is also small cell carcinoma of the lung. And finally, the histological variety with best prognosis, that will be your squamous cell carcinoma, right? That will be your squamous cell carcinoma, right? So these are some of the very important points related to your bronchogenic carcinoma, right? And you see a question here. A patient presents with secondaries to the adrenals. The most common site of primary is lung, kidney, breast, stomach. Where will be the most common site of primary? That is in the lung. Okay, so just now I have said you, from the lung to which particular endocrine organ most commonly the metastasis occurs? That is to the adrenal gland. Next question. A 60-year-old male presented to the emergency department with breathlessness, facial swelling and dilated veins on the chest wall. The probable diagnosis is thymoma, lung cancer, Hodgkin's lymphoma, superior vena cava obstruction. So what is the answer here? The answer is SVC obstruction. So in patients with SVC obstruction, you will have the dilated veins over the chest wall and as well as the facial swelling. And which particular type of the bronchogenic carcinoma is associated with the development of this SVC syndrome? That is your adenocarcinoma. Then followed by that, all are cavitating lesions in the lung except Kaplan syndrome, Wegener's, hamartoma, squamous cell carcinoma. So let me tell you, Wegener's, it is the granuloma formation, it is not cavity formation. Your Wegener's granulomatosis, it is a small vessel vasculitis. Right? Here in Wegener's, you don't have this cavity formation. And you see next question. A 65-year-old uranium miner presents with muscle cramps, early morning headache, chest X-ray and CT scan shows as follows. The options are small cell carcinoma brain mets, non-small cell carcinoma brain mets, pleural and intracranial calcification are there, glioblastoma multiforme, extracranial spread. So you can observe there is some non-homogeneous opacity, and within the brain CT you can observe the presence of the brain mets. And the individual is having muscle cramps, right? What would be the cause for the muscle cramps? That is mainly the hypokalemia. And there is also early morning headache, and that would be because of your metastasis as such. Now the point is, which type of bronchogenic carcinoma is associated with your hypokalemia? That is your small cell carcinoma of the lung, right? And how is that? Because it will produce it will be acting as a source of production for your ACTH. And ACTH is the one which will cause the hypokalemic alkalosis, right? And you see the next question. All of the following statements about small cell carcinoma are true except commonest malignancy of the lung associated with paraneoplastic syndrome causes SVC obstruction, chemosensitive, commonly metastasized to the brain, right? The question is, which is the incorrect statement? The incorrect statement is commonest malignancy of the lung is a wrong statement. Commonest malignancy is your adenocarcinoma, whereas in India it is squamous cell carcinoma, right? And it is associated with the paraneoplastic syndrome, that is it produces ACTH and it causes the SVC obstruction. And let me tell you, we had one more question just now, yeah, that is the SVC obstruction. So let me tell you, SVC obstruction it is seen in small cell carcinoma of the lung and then also seen in case of the adenocarcinoma as well. Also seen in case of adenocarcinoma as well. Okay, right. So, yeah, the answer here is yes, they are chemosensitive tumors and they commonly metastasize to the brain. But commonest malignancy of the lung, it is an incorrect statement. And next question is, clubbing is least common in squamous cell carcinoma, adenocarcinoma, small cell carcinoma of the lung, mesothelioma. Let me tell you, clubbing is least common in the small cell carcinoma of the lung. So these are some of the questions related to your bronchogenic carcinoma, right? So with this, I wind up this session on bronchogenic carcinoma. The treatment part I have done in an elaborate manner, and the treatment was mainly concentrated on the molecular profiling techniques, right? So this is a recent add-on, right? These are the newer drugs which we have discussed in the treatment part, and they definitely can be asked as your multiple choice questions. Thank you very much.